So of course, between 2006 roughly and nowadays, it's all about the soft tissue, and that is why Snezana and Attila, man, your work is incredible, and I can't wait to see you up here soon. So we know that soft tissue is a huge battle. It's very, very different when we're discussing implant versus tooth because of the connective tissue. So when we're discussing papilla, we've got preservation and regeneration are two very important words to take under consideration. So the mesiodistal distance between implants or implant tooth are of huge importance, and we saw Dr. Chu's lecture yesterday. And because of implant design and new concepts of implant placement, these distances are actually coming shorter. I personally have actually had good bone maintenance with numbers up to 2.5 millimeters because of implant design change. So vertical distance from the crestal bone to the contact point, of course, is still there, and the gingival biotype, the importance of a keratinized tissue, is of maximum importance. So we've gone through the numbers several times today. There is a direct relationship that has been demonstrated to exist between the existence of a minimal mesiodistal distance of bone between implants and the maintenance of adequate papilla. I guess is the most important thing from the study from Tarnow, which was later improved by Team Atlanta, which would take that out to the relationship between pontics, between implant pontics, tooth, and I would say that's one of the most pivotal studies in implant dentistry today. So this is, without a doubt, a guide to everybody on my team. It's a guide to the lab, and something as important as taking a perpendicular x-ray. So there's a rule in my clinic. If the x-ray is not absolutely horizontal to the cone beam, you'll get a false result in the measurements. So it's very, very important to make sure that the quality of your x-ray is well done. And we share these x-rays with our lab so that they can understand where and what we're talking about in designing our teeth. So in regards to gingival biotype, when placing, Linda in 2014 said that when placing implants in the aesthetic zone, the quality, texture, and appearance of soft tissue should be considered. So in a thin biotype, we'll have less free gingiva, less keratinized tissue, less bone support, and the contrary, obviously, in thick types. And of course, thick and fit is the right way to go, right, my Portuguese friends? So I would say that in terms of papilla preservation, from what I could figure, and I might be wrong here, we have socket preservation after tooth extraction. That's probably number one, and that's Danny Boozer, and he's been pretty strong on this since the beginning, and I don't think any implant surgeon today or any just general dentist would consider not regenerating a socket after extraction because of the studies. So orthodontic extrusion, initially described by Maurice, and it's what a game changer to be able to have that in your armamentarium. And guided bone regeneration, of course, which has been discussed over the few days. Restorative treatments, I've just shown you a few cases before. So for your surgeons, if you are exclusively a surgery and you have a patient that comes in and says, I need more papilla, and you don't understand the restorative side, call a restorative dentist, call a cosmetic dentist, find out if, or a prosthodontist, and find out if there's another way. Because we should always, just because there's a saying that if you're a hammer, everything that comes through the door is a nail. So just because you can solve some of these problems surgically doesn't mean you should, because there are other alternatives such as restorative treatments. And of course, surgical procedures, which we'll be showing in a bit, like soft tissue grafting and all the other amazing things that we've seen over the weekend. So let's get to it. This is a case which I presented the first part of last year here at Dental XP. And this is a patient, and this will present some papilla preservation, socket preservation after tooth extraction, some of those concepts. So here's a patient who was a heavy smoker for many, many years and wanted natural gingiva. She was very adamant that she did not want pink papilla. So, I mean, I can learn a lot from Alan over there, but this is how we decided to solve the case. So we sat with her and we discussed extensively with the entire team what to do. From day one, I wanted to save these lower teeth, the canine and the two premolars, because as dentists, I think we should primarily try and save teeth, because that's like our job. So we realized that all of the top teeth were lost. And here's the versadensibur that Isaac Tawil was talking about. Here's the smart dentine grinder, the result of that, as Isaac Tawil was talking about. So many people over the day, Alan mentioned this in his lecture, it's a combination of so many different factors that will dictate success. So it's kind of like the guy that walks into the surgery most armed with the most toys and tools and stuff will probably get the best overall result. So we placed his implants with PRF. Thank you, Joseph, for this incredible life-changing procedures. This is how the versadensibur works. So it's counter-rotational, and we're pushing that the xenograft up into the socket to try and get that socket preservation according to all the literature that's out there. And then we've got important things like implant size selection, you know, wanting to preserve that buccal plate. So having an implant which the core doesn't change after a certain number and just the threads do with a knife thread. And for those of you that saw Professor Park's lecture, this design really helps preserve the bone. And I think that is also another key factor for why we had a good result here. Had I used a 6mm implant, that would have eaten out all the bone. But here we've got a 5.5mm implant, but the body is only 4.3. So the screw is not eating out the bone, which will then support what Joseph Shukun was saying of not putting pressure on the bone, which reduces ischemia, which enhances longevity. So this is post-op. We don't have primary wound closure in every area. Why? Because we use the PRF. So you guys explained that wonderfully today. And then I finished my surgery, but I made a mistake in this. I made a mistake in the surgery, and you're going to see it in a bit. And I think it's important to own mistakes because I should have known better. And then when I finished, I just went, "Duh!" like Homer Simpson, and you'll see that result in a bit. This is like you were talking about, Raquel. This is low-level laser therapy, which is a French company. They do this, so we just offer that to our patients. Yeah, yeah?
I'm sorry.
So with no surgical guide, this is a freehand placement. You can see different implant sizes for different areas. And we immediately took our impression. And I think it was 48 hours later, we had a screw-retained PMMA that went into the mouth. So this is 48 hours after the surgery. And again, everybody's been discussing this over the last 2 days, the importance of speed in these cases. And after a few months, we start having beautiful soft tissue modulation. And one of the things that I think was also important, not just the implant size, the positioning, the guided bone regeneration, the PRF, the versadensibur, all of that, but also the fact that we used the interface, so the one abutment one time. So we don't have to touch the soft tissue that many times. And again, it's very important to have a huge selection of these multi-units in your clinic because sometimes you never really know how high you need them. And again, the AnyRidge system has a wonderful set of those, a huge amount of them actually. So here we're testing occlusion. So Carlo Poggio, you know, this is the most important thing is to make sure that occlusion is stabilized because that will also affect the outcome in the long run. And after 3 months, I had very stable ISQ measurements and we went for the final situation. So honestly, again, not very happy with the overall aesthetics of this case. But here you can see the zirconia abutment. Not so much here, but why? I didn't do socket shield. I didn't do partial extraction therapies. So I had that in my armamentarium, and this could have been the case, the end all cases that we had. We threw the whole book at it, and I didn't do that. And as a result, I mean, the patient's happy. She's fine. It's hygienic. It's all right. It's out of the aesthetic zone. And here we have a 1.5 year follow-up. So it's kind of stable. But had I done the socket shield on the canine area, I don't think I would have had this result. So this is also kind of proof of concept that a socket shield really does come in handy in your armamentarium. So, but again, she's pretty happy with the pretty stable result. So one of the techniques that we discussed for papilla preservation is orthodontic extrusion. This is an old case, so please forgive the quality of the photographs. And over about a 10-month period, we slowly extruded this patient's lateral, who started up here. And again, forgive the quality of the photograph. We did a root canal on the tooth and slowly extruded it according to all the documentation in Salama's presentation. And then once we were ready, because all of the ligament follows it, so the bone and the soft tissue, it has to be done very slowly. Once we were ready, we extracted the tooth, we placed an implant, and at the same time regenerated with some soft tissue, as Ashraf showed so beautifully and masterfully in his presentation. So here we have the temporization, and waited a few months for that. I would not probably do this today. I'd probably do more minimally invasive, but you'll see why in a bit. And here we have the ceramics, and we have quite a good papilla level there. And that's actually for 9 years now, she's had that quite stable in the mouth. So the orthodontic extrusion is a very good, for those of you, how many people here are surgeons and work with an orthodontist? All right. How many people have done orthodontic extrusion? It really works. It's a great thing. So thank you, Maurice, for showing the world to that. So again, in order to get papilla preservation, socket preservation and soft tissue grafting simultaneously is incredibly important. Here we had a patient with aesthetic complications. We did a full mouth treatment plan for this patient, and we had a lost central. So in this case, that tooth was totally unsalvageable. And as you can see here in the CBCT, we had quite a large lesion as well. So everything that I was trained to do 15 years ago was, this is counterintuitive, to extract and place immediate implants when you have socket defects like this and infections. But of course, throughout time and with everybody participating with the science and the evidence, we now know that we can do this. So that's why it's so important to attend these meetings and to go on Dental XP and spend some time and learn, because at the end of the day, you can spend less time in the chair with your patients and have better results. So we took out that tooth, we cleaned, and we placed a connective tissue graft, autogenous bone that was harvested. And again, Maurice, I was doing this wrong for the first 5 years of my career, which was I was doing high-speed rotation at 800 RPMs, and I was, hey, I've got loads of bone here. And Maurice told me that, thanks to your study again, Eduardo Nitwa, okay, well then, you told me about this, which was under 220 RPMs. And again, so many people don't know that study. They're still using the bone to regenerate at 800 to 1,000 RPMs. And it's not good bone. It's not going to work. It's dead bone. So that's why my protocol is pilot drill and up to 2 millimeters. I'll do high speed with saline. And then after that, I will go very, very low speed, so 150 RPMs, which is well under the numbers, so that any of that bone that I harvest is good bone to use. And these drills really get a lot of good autogenous bone. So we've got some soft tissue grafting as described in literature. And here I'm placing the AnyRidge implant. And this tends to go subcrestal. And as you can see here, shukrun, no pressure on the cortical bone there to let that soft tissue come in, the healing come in. ISQ always. This is called a PMMA fuse abutment. It comes with the AnyRidge system in different sizes and shapes, and it really helps do immediate provisionalization. And this is on the day of the surgery. Whole thing took about an hour and a half. And after a few months, we've got beautiful soft tissue healing. We relieved the pillar there, but we know that that bone is going to be supported because of the kind of procedures that we did, and we didn't cut any corners. We did everything. Provisionalization, and after a few months, the final restoration. Nice bone volume there. And we actually presented this in a study which came out in PubMed about 5 months ago, where we did an immediate loading of single implants in the anterior maxilla, a 1-year prospective clinical study on 34 patients, where we actually had a 100% success rate. Just except 2 implants, we had to wait and do a delayed loading. But on all of these implants, so 41 implants, we did this protocol with incredible success. And of course, we have to follow the protocol, and this is using the AnyRidge implant. So this is the end result. And pretty stable. And again, we've seen all the lectures today, and everybody kind of is coming to the same conclusion and why this is happening. So high smile line, so it really was important to not fail in this case. So some tips in doing these really complicated cases. Try and see the end game from the very, very beginning. So when you're discussing these delicate patient management cases that have so many things to go wrong, try and actually do the whole treatment plan, including all the potential failures till the very end of the game, so that once you start, you have, as the French would say, carte blanche to work. So even if you have to use more materials, use more armamentarium, do some more socket shield, get some more soft tissue, you're free to do it. And it really helps your mentality when you go into these cases, which is pretty much, let me do what I need to do to get you good. And turn your patient into your partner and not into a client, because when these things go wrong, you will have problems. And of course, make sure that everybody in your team is involved in these complicated cases. So here's another case where we did the same kind of procedure, where we lost the entire buccal plates in a patient that lives in London, and high aesthetic demand. She also wanted to improve her smile and close the diastema. And she said, she literally said, I would like a papilla. So not only, I'd wished that we didn't have this root fracture, but we did, because quite frankly, in terms of my philosophy, which is avoid stress, I would really much have preferred just doing a root canal treatment on this patient and some veneers than having to go through all of this, because it's a huge risk every time we take on these cases. So, of course, the only thing we can do here is full extraction. This is an aesthetic buccal flap as described in the literature, and there's no bone here, absolutely no bone. So what do we do if we want to get this out of the door as soon as possible, predictably? So here we got PRF mixed with a xenograft. We packed that in, and then all of the science that Shukrun described starts working immediately. And I need to place my implant in an ideal zone. So here I'm going to place a 450 millimeter AnyRidge in an ideal position, stress-free. So don't want to put too much torque on that. Then a PRF membrane to cover everything up. Here I decided to use a collagen membrane, but I've stopped doing that, Shukrun, because of what you've been publishing. I also decided to throw the entire book at it. I got some soft tissue. I took off the keratinized portion of this with 11 blade, and I just put that on the side. I measured my ISQ to make sure that this implant was stable, because we know that if I can get my immediate crown there, that will really help support the soft tissue. And again, with the ISQ measurements with this system, there's a very easy guide that was done over tens of thousands of implants, that if, with this system, if you have over 70 ISQ, you can load these implants. And these tools are very, very important. So it's really, really cool to be part of these meetings, because every single time, like, you go back to work on Monday, right, tomorrow you've got more tools in your armamentarium. I mean, sometimes the bummer thing is that they all cost a lot of money to get them. But it's so cool that they're there, you know? So, and thank you, Professor Park, for the study, because it just gives me so much more security. It helps me. So the design of the implant, plus all of the science of the soft tissue and the hard tissue, and the different protocols of submerging are giving me more and more confidence to get good results. So here's that little soft tissue disc that I put in there. And I'm going to go and do my immediate crown, which I took out of occlusion. And here's the X-ray. So this fuse abutment is actually designed to break under stress, so that if you don't do the occlusion very well, it will break. And your patient might not be happy that the tooth is broken, but the implant will be saved in these initial times. And again, have you ever wondered why bone surgeons have it easy? So let's imagine you have a surgery on your ankle. No patient in their right mind would ask their surgeons, sorry, I just bought a new pair of Louboutin shoes, and I need to wear them because I've got a party to go to tonight. But all of our patients ask us to have functional aesthetical smiles in the intermediary healing phase. It's really unfair. So this is long distance healing. Okay. And again, she had incredible healing, and this is after 3 months. So I operated her. She flew to London. She took the stitches out in Harley Street with a friend of mine, Dr. Navarro, who's a very, very talented friend of ours. And he took his X-ray, said everything's fine. I was like, phew. And we've got some good bone. And after a few months, we took the CBCT. Everything seems to be right. We got osseointegration. I measured the ISQ. Let's go straight to final. So we take the impression, like you, Isaac. I like to put a bit of flowable around the open tray impression. And then our lab I was testing out a new lab here. We made a customized zirconia, and this is everything in place with the S-line. And for those of you that saw Professor Park's impressive lecture, this here is where the magic happens. You know, it's new paradigms. So on the day of cementation, damn it, I've got a little gap there. She's going to complain. Now remember, she had a diastema originally. So we've got these 4 interior ceramics, and I'd lowered the contact point according to the literature in your study, Maurice, and I said, let's wait. She says, oh, but I want the papilla. I said, trust the science, trust the science. And she was stressing out a bit. And the truth is after 1.5 years, we've got it there. So like good wine, sometimes it's good to wait. And I mean, there's something in the old wisdom. You know, you'll find that the older the dentist, the more they say, just relax, it will be okay. You know, don't be so stressed. Give it time, it will heal. Here we have the 1.5-year CBCT, and we're pretty happy with that. So those were the old tools. Those were everything that was described in the literature. Now we've got the new stuff, which is the partial extraction therapies, new materials. I've just mentioned it a bit, like the implant designs, abutment designs, very, very important. And of course, the guided surgery. Is guided surgery, and this was the question that I wanted to ask, is this a new therapy? Is it a new tool in papilla preservation? So I challenged my team, and I'll challenge you to see if this is something that we could include in the armamentarium. So I called up Maurice, and I said, because there's still so much, there's some discussions to what is what. So let's put an end to that here. A partial extraction therapy is exactly that. It's a therapy is a term first described in Dental XP in 2015 that encompasses any and all terms and procedures that involve the maintenance or utilization of all or parts of the tooth root, PDL and cementum above and below the alveolar bone to preserve rich form and soft tissue levels. So this first started as SRT, submerged root technique, in 2007 by Salama and Ishikawa, and then onto socket shield technique by Hertzler and Zur, root membrane technique by my very good friend Mitzias, and they've just come out with an amazing kit to help dentists perform the root membrane technique, and of course Pontic shield, and my very good friend Gluckman, I think, whose name was repeated here many times over the past. And there's actually even the proximal socket shield as described by Kahn. And thank you, Mo, for that piece of that pearl of wisdom. This is a great article, Kahn, 2013, in the International Journal of Periodontics and Restorative Dentistry. It's an amazing article, and take a photograph of the screen, go download it and read it. So what are the partial extraction therapies? Socket shield, Pontic shield, partial extraction therapy, root membrane, and proximal socket shield. And Bernardo, what was your one? Selective socket shield. So we got to add that there, okay? All right, buddy? Sexy socket shield. So I'm almost coming to the end of the presentation, and this is, not many people associate me to socket shield, but this is a case we did quite some time ago, and the reason why I didn't show it is because I probably only ever saw the patient 3 times. So this is a young guy who lives in Toronto, and he came to visit his sister in Portugal, and his sister came to the dentist, and he said, could you just look at my front tooth? It feels weird. And I was like, wow, that's so cool. I have a great case. And this kid had never been to the dentist. He'd never been to the dentist. I said, I need this guy to have a great experience. So what can we do to help him? So the tooth, literally, I grabbed it with the forceps, and it came out. Remember, before you go into the game of touching a patient's anatomy in the aesthetic zone, make sure you've resolved all emotional issues and all financial issues. Prepare for failure, plan for the worst, create incredibly complex expectations for this patient, lower them completely, tell them that most possibly I will fail. Honestly, you don't want, it's so important, that first appointment. It's so important. So we had that out of the way. He gave me carte blanche, and here we are doing the socket shield, as most of you have explained so much better than me, keeping that front tooth there. Howard Gluckman was here last year. He did a brilliant presentation on this. So here I'm placing a 4mm diameter any-ridge implant into the socket, and guess what happened? I had a low ISQ. Now you saw that study that came out of Korea from the MegaGen team saying that if it was under 70, I couldn't trust this implant to load. But we know that I need the loading in order to maintain all the soft tissues, and it would just complicate life a little bit. So what can I do here? Anybody want to guess? Hey? What? Weight. Okay, we got the guy who likes wine there. Snejana, what do I do here? Individual healing abutment Maryland Bridge. Attila, what do I do?
Go for wider.
I go for what?
Wider diameter.
You're the man. That's exactly what I did. I took it out. Implants are not made of gold or diamonds. They're tools. And if it doesn't have the right fit, just take it out and put in a fatter one. And one of the cool things about this AnyRidge system, again, is the thread. So the diameter of the implant doesn't change, just the knife thread. And I got a beautiful 75 ISQ. Here you can see the CBCT, according to everything that you guys have been talking about. So I felt cleared. We have this immediate abutment, which is called an easy post, different sizes, all respecting the S-line, the cuff, the platform switching. And I packed some xenograft with some PRF in there, and I felt good. I said, what else can I do? Let's get some soft tissue. I took off the keratinized tissue. I just took that from the tuberosity with the tissue punch, very easy. And then I packed composite into the pre-treated, his own tooth, and I just put it on top, and I bonded it, and that was it. So 1 week after that, he came in. I wanted to make sure everything was okay. And I said, look, I want to take an impression so we can make you a screw-retained immediate PMMA. And he said, doctor, I don't have time today, but I'll come back tomorrow to take that impression. Because I wasn't 100% happy with the adaptation. And anyway, he came back after a year and a half. So, and he just walked in the clinic, no appointment. And I was like, oh my God, I'm so happy. He says, doctor, I leave tomorrow. So I really didn't have time to do the proper thing. But I mean, look at that. That's after a year and a half, immediately after the surgery. It really does work, and we've proven that over and over again. So then just my lab very quickly prepped the abutment that comes with the system. But look how thick that tissue is. Oh, and by the way, this guy had a diastema to start out with, if you remember. And we made a monolithic zirconia crown. That's why it's not that aesthetic. He didn't want to close the space. And that was the final restoration, and I haven't heard from him again, except I managed to get him to go to a dentist in Toronto that actually said everything seems pretty stable. So Socket Shield is a great tool for that. What about new materials being developed? Well, as you saw in Professor Park's lecture, with this AnyRidge system, the choice of the platforms you have, the design that is all very around the soft tissue, the new techniques for placement, which is sinking, submerging the implants, just like Alain Simon-Pierre showed you, the connection types, platform switching, the length, the cuff, all of these things, and our abutment selections, as we have seen throughout the morning, very, very important to, Ashraf showed some beautiful cases of creating that emergency profile just with his abutment selection. So sometimes you don't have to be very skilled surgeons, and I don't know if you know this, but Megagen actually makes a 10 millimeter wide abutment, healing abutment. So imagine taking out a molar, placing an implant in optimal position, packing some bone around that, and then just placing a 10 millimeter healing abutment. It pretty much occupies the whole socket. And it's really, really easy. And of course, the ultimate, just to finish my presentation, is 3D assisted surgery, which I think is the future in socket preservation, in everything. It's keeping it simple. And I would like to introduce to you a charity case we did in Portugal of Tania. So somebody reached out to me on Facebook, and that's one of the cool things about Facebook, and said, listen, this girl's going to lose her son. Her son is 4 years old. She doesn't have a husband. She can't get a job. And I'm like, yeah, can't get a job. And then I saw her, and she literally has no teeth. And so I wanted to help, because sometimes we have spare time, and instead of spending money in shopping centers and buying TVs and stuff like that, sometimes let's use our resources to help people, because that's really part of a bigger game. That's where the fun is. So we brought her into the clinic, and she was just devastated. She'd lost her soul. She was a disconnected human being. She'd lost her self-esteem. No wonder she didn't have a boyfriend. She couldn't leave the kid alone. She hadn't eaten in a few days. So a bunch of people got together and paid her rent for like 6 months, got her a child nursery. They filled her fridge, and they got her a job at a local hotel cleaning rooms But the owner of the hotel said, we can't hire her, she's got no teeth. So we then reached, this is the initial photograph, massive loss of vertical dimension, absolutely no papilla whatsoever. I mean, it's the last thing on our mind right now, you know? And I mean, a pretty tough case. And for people that can't afford to eat, comprehensive dentistry is just off their wish list. It's just, you know, so sometimes if you have a little bit of extra time, reach out to your community and save a life, change a life. It's really cool. So we, on the very first day, we said, look, let's give her the best papilla we can. So we took out the teeth. I left those 3 roots because I learned my mistake. I wanted to do a socket shield. And we placed, so here we've got, you know, this supracrestal fibers there, maintaining, of course, the volume and the anatomy. But here's that perfect papilla. This cost me 150 euros to make her, and she was happy as hell, man. She was just back in the game. And that's with the 150 bucks, because when you take out teeth, and by the way, I want my new forceps, those spring ones, because that would have really helped me here, buddy. You know, right, Martin? So just a partial denture, she's so happy, and it was incredible. But anyway, so I called Korea, and I said, guys, you're working on this R2 gate digital guided, and I have a bit of experience with the Coachmans and a few other systems. I'd like to test it. Could we test it? Could you? So they hooked me up with their team in Korea with a guy called Jong-Chul Kim, who invented this. He's a genius. If you ever get a chance to see him lecture, it's like mind-changing. So there is going to be an event in October in Japan, and I invite you all there to go there. It's going to be really, really fun in Tokyo, and you'll see Jong-Chul Kim explain this. So the exceptional thing about this is I didn't do this case. I can't take credit for this case. I had my young team scan according to the protocols. They sent it on the cloud, and the cloud designed stuff, and then I got a DHL box with this in it. And then my team basically, throughout this time frame, they did some restorative on the bottom. And now, after 5 months, we were good to go. So I pretty much rock up. The patients had the anesthetic, and I just insert the guide that has these special little niches here, which are for implant positioning. Notice there is no metal cylinder. And we saw a great lecture earlier today that explained the differences with this. And the notches, so you know, the hex position. So this is fully guided implant placement. Now remember, she has no papilla, okay? And so here we go. Under local anesthetic, we're going to place those implants. They teach you what implant to use, what sequence to use, what drill to use. It's pretty simple. And here we can see the implant going in. And there's the stop there. So you can just put it in, and it will stop. Easy as pie. And the truth of the matter is that I think all of these advanced surgeries that we've been skillfully doing over the years, their days are numbered because the robots are coming. And the robots are coming. So then we did a socket shield. Here we're going to do a root submergence because we are going to fulfill the partial extraction therapies. So I did 2 socket shields and a root submergence. Well, later we grind that down to the bone level. So here you see the protocol. And we packed some bone in there before, and we used the surgical guide to actually insert. So this is a fully guided socket shield in the aesthetic zone. And same protocol, ISQ as described before. And we 3D printed this insertion guide. What for? These are actually the final customized zirconia abutments. Final customized zirconia abutments that are going to go into place. We guide them. See, we've got the root submergence happening there. So we're using another PET technique. And that's going in place, and we torque it down. Now, some of the margins are a little bit high, so I just grabbed my burr and I redesigned them. And we torqued that into place. 1 abutment, 1 time, and pre-made, pre-designed, pre-milled PMMA structure that was cemented just with some temp bond. And the whole thing took about under 2 hours. I think 1 hour, 45 minutes. That usually would take a skilled surgeon probably 3 times that time to get it done. And you saw the cases, the analog case I showed you, I could only get the teeth after 48 hours. So the robots are actually helping us. These software is actually helping us. Why didn't I place the implants and the restorations on the bottom? Because I didn't oversee the initial impression, and somebody had delegated to an assistant to take the impression of the lower, and they didn't alginate. So it wasn't perfect. And if it's not perfect, don't do it. Okay? Don't trust anything. So, but you can see this is after 1.5 hours. We've got the root submergence, the partial extraction therapy, 2 socket shields, and this implant perfectly placed. And we then stuck to the, here you see the CT scan. Everything's nice according to the protocols. We measured the ISQ. Oh, sorry, I must be pressing the wrong button. There we go. So we did the low-level laser therapy. And this is her 2 hours after we had to wait for the anesthetic to subside. So basically, we finished the surgery so fast, she was still under the anesthetic. Look at, she hasn't seen herself in the mirror yet, but look at her. There's no stress in those eyes. And I made a little accelerate. This is after, how many days do you think this is after? Attila? How many days? 7. See, you know your stuff. This is actually 5 days after the surgery. We already can slowly start seeing why, because of all of the things that I mentioned before, shape of the teeth, proximity, etc., etc. So we're actually very, very excited about presenting this final case in Tokyo. We're still halfway through it, but this is after 5 days. So I think that according to everything I've mentioned today, almost certainly we will manage a good papilla here. It's quite incredible. Now she's seen herself in the mirror. So this is on the same day of the surgery. This is how she walked in, and this is how she walked out.
Amazing.
She's a different human being, and this is thanks to technology and science and great teamwork. So this is a little speeded up video of behind the scenes. So it's all about the preparation. I'm very, very lucky to have a bunch of wildly talented people working with me, and I really, really can't take credit for this case because the only thing I did was just put the implant through the hole. Everything else was planned by incredible engineers and scientists and 3D printers and stuff. So once we finished, we waited a few months, and we decided, hey, let's do a full digital workflow. So we scanned the patient, we scanned the abutment, and so we did a full mouth scan there, and we sent that to the lab in Romania, who was very kind to offer this case to us. And, this is a statement that I like to have every now and again through my lectures. Sometimes it's important to have the technology in your clinic. So if you don't have the technology in your clinic and you're thinking of buying a Bentley, don't buy the Bentley, buy the technology. It'll make you a lot happier. So we have the technology, and they did a full digital workflow. They sent us. Now look, this is done by robots. Look at the abutment here. Look at the abutment here. That's the try-in abutment. Look at the crown here. That's the try-in crown. There's no gap. There's no nothing. These things are pretty precise when you follow the workflow. So here's the clinical, and that's about a week after cementation on the bottom. We then used the face hunter to determine a vertical dimension for this patient. So we decided to go full digital. What's the future going to be like? What would be a full digital workflow on this patient? And this is the 3D print of her impression. So then I said, okay, mill me a zirconia infrastructure, and let's see if it's reliable. So they milled me a zirconia infrastructure so I haven't taken any impression so far. And this is the try-in of the zirconia infrastructure, which will now just take feldspathic stratified ceramics over that. But look how perfect it is. And there you got the root submergence and the socket shield, and everything's working. And look at all of the beautiful soft tissue there. And technically now I would send this to the lab, and they'll just add ceramics, and I'd be finished, and I'd be showing you the finished case. But the reason I'm not going to show you the finished case is because I wanted to create more complications for myself.
Hello everybody, my name is Eduardo de la Torre. We're recording this video from Madrid. First of all, I would like to apologize for not being able to be there with all you guys. One of my team members, my orthodontist, is getting married, so I'll be down in Granada. And well, I wanted to talk about what happened like a month ago in New York. I had the chance of lecturing there together with my good friend Miguel Stanley, and he talked to me about Tanya's problem and the loss of her smile. Immediately there, we wanted to implement the concept of the digital smile donator created by our very good friend also, Christian Coachman, and I thought that Sophie would be a great candidate to donate her smile for Tanya's problem. So it's amazing what we can do nowadays with digital dentistry and with the use of the cloud by scanning a patient and transferring this information, and even being in separate countries, being able to donate this smile for Miguel's patient. Something that I'm really happy that we've done, and I really hope we have many more cases to do and share together in the future. So thanks again, Migi. And would you like to say something, Sophie?
Yes, I'm really happy to help Tanya, and I can't wait to meet her with her new smile. Bye.
So Eduardo scanned Tanya.
Goodbye.
She scanned his wife's beautiful girlfriend's smile, sent it to the DSD center where they superimposed and adapted to Tanya's dimensions. Then sent us the STL file. We printed her teeth. Look, she's only got one premolar. I mean, can't get more natural than this. We made a silicon index and injected the PMMA over her pre-existing abutments. And that's true generosity when that changes the meaning of really giving somebody a smile. So we hope to be finishing this case for the MegaGen Symposium in Tokyo with the final robotic fully milled zirconia structure. And this is the power of dentistry. With nice papilla.